Okay. Hi all, welcome back to this session. Now we will continue with the next drama by Dr. Noor with title of Oral Biopsy and the Pitfalls. Okay, welcome Dr. Noor.
Right, hello everyone. I hope you can hear me. All right, while waiting for Dr. Mesh to load the presentation. Okay, now this next lecture, a bit on the technical side. So you get to see what we see as neuropathologist, what we see under the microscope. All right, but not into great detail because we're not really making you a pathologist, but just to let you understand what is it, some of the problems that we face when we see your biopsy specimens. Okay, all right, so now I hand over to Dr. Mesh. Thank you. Hope you enjoy the lecture.
Our next lecture is oral biopsy and pitfalls. Now, this lecture will look at the problems and the limitations that is encountered when you carry out oral biopsies from the perspective of the oral pathologist. Okay, so when a patient presents with orofacial diseases, especially oral lesions, proper management of these lesions is very important, and we need to get the correct diagnosis in order to properly manage these lesions. And so taking a biopsy would be a gold standard, especially when we are suspecting a malignancy. So procurement of sample or biopsy is important in the diagnosis of oral diseases. Good understanding of the biopsy techniques and the possible challenges or pitfalls involved in the procedure itself should be the best guide to the clinician to acquire an adequate and representative tissue sample. Now, this will allow the oral pathologist to interpret the lesion, and so that the surgeon will be able to carry out the proper treatment for the patient. Now, the ability of the oral pathologist to interpret a lesion correctly is dependent on a good biopsy performed by the dental surgeon or the dental officer. Okay, so what are the limitations and pitfalls of oral biopsy? Limitation is a condition which limits the quality or an achievement. Now, taking a small sample may not be representative of the whole lesion, and also a small tissue would have inadequate features to provide a definitive diagnosis. Now, sometimes the anatomy of the area involves also limit the tissue that you take. Such, for example, gingival tissue, because you know the gingiva is tightly bound to the bone, and so you can get only a very thin sample. So this also becomes a limitation when it comes to diagnosing the lesion. Pitfalls is a problem that is likely to happen in a particular situation. An example is use of instrumentation that can lead to artifact errors which may compromise the final diagnosis. An example of this is the use of cautery, which can cause a thermal artifact. Inadequate, wrong or poor quality fixative media may cause improper fixation, which can also compromise the histological features. Now let's take a look at some common occurring challenges or artifacts encountered by the oral pathologist. Small and thin biopsy. Now, thin tissue which lacks supporting dermis will curl up, and this makes sectioning difficult. If the tissue is too small, then there will be inadequate tissue available, as some of the tissue sample will be inadvertently lost during the lab processing. Now, for those of you who are not well versed with what we do in the lab, the tissue will need to be put in wax, and this will be trimmed and sectioned before they can put on slide. And this process, some of the tissue will be lost due to this trimming process. So if your sample is very small, then a lot of the tissue would have been removed during the trimming. So there's not much of the tissue sample that's left. So how to prevent this? Now you require an adequate depth to include both the epithelium and the supporting tissue. Now if the tissue is thin, then placing the tissue on piece of cardboard or hard paper before placing in formalin prevents the tissue from curling up. And you must also remember that fixative solution will further shrink the tissue size. So an adequate sample size is advisable. If you take a small tissue, you place it on formalin, once it's fixed, it will shrink even further. So there's very little tissue that's left for examination. Now, the second challenge that we face is tissue orientation. Now, it's often difficult to orientate or distinguish the tissue margin if there are no distinguishing landmarks. Now, this is very important when the margins are required and when you are removing a malignancy and you want the margins to be reported, these margins have to be oriented properly and marked or labeled so that the pathologist will know how or where to place it, because once it's out of the mouth, it's difficult to actually orientate the tissue properly. Now, you try and think, you put it, if the tissue is labeled the buccal mucosa and there's another one labeled as lip. Now, out of the mouth and after it's been fixed in formalin, it's very difficult to decide whether the tissue is the buccal mucosa or the lip because they look the same. And so that's why you need to, if you require margins in this area, you need to properly label and orientate them properly. Now, just to share with you what we oral pathologists see under the microscope. Now, this is looking at a thin tissue. You can see here, this purple colored area is the epithelium and the pinkish colored area is the connective tissue. So you can see this tissue is a little bit thin and it's fairly long, but it's thin, and because of that, it curls on its side. All right, now you can see here as well, the epithelium is thickened, but you've got very little connective tissue here. Now there are sometimes this is inadequate to provide the diagnosis, especially when the lesion is actually deeper than the tissue given. All right, now this slide is to demonstrate what I meant earlier on about adequate depth. Now, for lesions which have very thickened epithelium, like this one here, or very thick keratin layer, or are corrugated or nodular, or have this papillary surface appearance, you require a deeper tissue depth in order to have adequate sample, especially if you are thinking of a malignant lesions. And you can see here, this appears adequate. You think you've taken enough, but in actual fact, you see you've taken very little connective tissue. And if we want to diagnose this as a malignant lesion, we need to see invasion into the connective tissue. So if you have very little connective tissue, then it's very difficult to demonstrate that invasion. And so we cannot diagnose it definitively as a carcinoma. Another challenge that we face is sampling error. For example, biopsy from a necrotic area such as the center of an ulcer, inadequate depth, especially for a lesion which is very deep in the submucosa. Now, sampling error can result in the sample being reported as non-specific, inconclusive, or inadequate. Especially cases suspected of malignancy, features of infiltration by neoplastic cells must be visible histologically. Now, this is, as I mentioned before, that we need adequate depth to see the invasion in the connective tissue. So how to prevent or minimize? We have to avoid ulcerative center because here you can only see necrotic tissue and nothing much else. So you may miss the diagnosis. You also need adequate lesional tissue sample in your biopsy sample. Now, what we sometimes see is we see a lot of tissue which is taken at the margin of the lesion. So we only see a small tissue which is taken from the lesion, and sometimes the features are inadequate for us to give a definitive diagnosis. Now, for vesicular bullous lesions, we require tissue from the perilesional area. Now this means tissue from surrounding the bullous rather than from the bullous or the vesicle itself. Because for vesicular bullous lesion, we need to demonstrate the split in the epithelium. Now, if you take from the bullae or the vesicle, the epithelium is very fragile because they have split in that area. And so when you take, the epithelium will just peel off. And so we will not be able to view nicely that split in the epithelium. Now, for large samples, you may require multiple sampling in order to avoid sampling error and in order to get adequate tissue of the lesion itself. Adequate depth is of course important. Minimum is 5 mm, but you must remember you need to factor in the shrinkage due to the formalin. For infected lesions, the presence of dense inflammation within the tissue will mask the histological findings. Now, this may make the definitive diagnosis difficult. For example, you are thinking of a dentigerous cyst which has occurred together with an infected wisdom tooth. But however, the infected wisdom tooth is diagnosed as having pericoronitis. And so there is already an acute inflammation there. And when you take the sample from that area, the cyst will appear as an inflamed cyst under the microscope. And so it resembles more of a radicular cyst rather than a dentigerous cyst. And if the clinical information that is given the pathologist is inadequate, it's very difficult for us to distinguish the dentigerous cyst from the radicular cyst. Now, fungal infection can also worsen dysplasia, especially for potentially malignant lesions. If they are very red and is painful, there probably be a secondary fungal superimposition. Now, it may be best to take the biopsy after treatment with a simple topical antifungal or an antiseptic mouthwash to reduce that fungal infection. Only then you can fully assess the dysplasia. So for lesions showing signs and symptoms of acute inflammation, it is best to treat the acute phase first prior to biopsy because it can complicate the final diagnosis. This is to show you necrotic tissue. All right, now you see here there's nothing much cytologically interesting here. You see very pink tissue with these blue dots of inflammatory cells, and you don't see much of any specific histological feature. You can see some bacterial colonies here and here. Here is a slightly higher power view. You see very pink tissue, and here you see degenerating epithelial cells. And so there's nothing much we can say about this tissue except it being a necrotic tissue. Now this slide here is to demonstrate infected or inflamed lesion. Now take a look at this lesion here. There are two different areas that are slightly different. Here is a very inflamed area. Here is very less inflamed. Now if you look at this very inflamed area, you see the epithelium here. All right, there's loss of corrugation of this surface epithelium. You can just about view the keratin layer here, and you see the epithelium is hyperplastic, and this is secondary to the presence of the inflammation here. But if you look at this area here where there's very little inflammation, you can see there is surface corrugation here, and then you can view the parakeratinization here quite well, and you can see that the basal layer of this epithelium is flattened, not like here. All right, this epithelium is quite thin. You can see here is very little inflammation. Now, this is features of odontogenic keratosis, and so this is actually an OKC. But if you were to take a biopsy at this region here only, then you will not be able to diagnose this as an OKC. We need to see these features, specific features of OKC here in order to definitively diagnose this lesion. Now, administration of LA directly into the site of the biopsy can cause cellular alterations. This can affect the histological features which may influence the final diagnosis later on. So it's best to administer the LA in the tissue surrounding where you want to do the biopsy or in deeper tissue. If it's possible, use regional block instead. Now, gripping or holding the tissue with tissue forceps can result in crush artifact. This can compromise the histological features of the sample and can produce tissue tears and microcysts. Now, this paper by Sion et al. In 2002 reported that crush artifact is the most common artifact. So to avoid this, it is best for you to place a suture in the tissue sample being taken so that you do not have to grip the tissue at the site. Now, this is also very important when you are doing vesiculobullous lesion. If you're gripping using tissue forceps, the epithelium can just peel off. And so you may not be able to view the split as I mentioned earlier on. This slide shows you how crush artifact look histologically. You can see here, this tissue here, you can see how it has been pinched here. And you see how the tissue here has been distorted. Now this is due to the teeth of the tissue forceps compressing it tightly. Here is a higher power view of it. You can see the tissue is crushed. You can see the cells are all squashed together. So it's very difficult to see the cellular detail around this region due to this crush. Using colored antiseptic to clean surface mucosa for biopsy site, such as the use of povidone iodine, can induce tissue modification as it can stain the sample to be submitted later on. So it's advised to use a non-colored antiseptic such as chlorhexidine if the surface disinfection is required. However, toluidine blue do not interfere with staining. Most of the oral biopsies are carried out by scalpel biopsy, but there are times when electrocautery or laser are employed to do the biopsy. Now, laser or electrocautery can produce thermal damages and artifact to the tissue sample. This thermal damage can make it difficult to evaluate the tissue, especially if the tissue is suspected of dysplasia or it is a malignant lesion. Now, when the margin is crucial. Now, if you have taken adequate tissue at the margin and the margin is clear, then it should not be an issue. But if there is dysplasia or tumor present at the margin, then the presence of thermal artifact at this area can make it difficult to assess the degree of dysplasia. This is how thermal artifact looks like under the microscope. So this is here is where the thermal artifact is. Here you can see there is distortion of the tissue. You can also see that the color where there is thermal artifact differs from the other tissue here. All right. Sometimes we receive samples which have inclusion of undesired material in it, such as sutures, tissue clips, and calculus. Now, this presence of this material can suggest a wrong etiology of foreign body reaction. Inclusion of calculus in your tissue sample may histologically mimic actinomycotic infection and thus give you a wrong impression of what's happening. So wherever possible, try to avoid including this foreign material inside your sample. Now, I cannot reinforce adequate enough that we require sufficient amount of tissue. Limitation in tissue sampling may compromise the final diagnosis as the features may be inadequate to achieve diagnosis. Sample may also not have included the representative area, so again, it gives you a wrong diagnosis to the lesion. Now, again, I would like to re-emphasize that shrinkage can occur during fixation. So you actually require an adequate size sample because you must remember fixing the sample in formalin causes shrinkage, processing of the tissue will cause loss of tissue. So you actually require adequate tissue for the pathologist to formulate a diagnosis. This slides just to demonstrate the inclusion of foreign material in your biopsy sample. Here are some suture materials included in your tissue sample, and here is a vegetable matter which has also been included in the tissue sample that has been taken. This is another sampling error, tissue taken not from the representative area of the lesion. Now, the clinical diagnosis for this tissue was mucosal, but as you can see here, you hardly see any mucin, but you just see some connective tissue mostly. So this, again, the tissue is adequate, but there is error in the sampling of the lesional tissue. All right, now this slide demonstrates inadequate depth and tissue not representative of the lesion. Now, this is a case of swelling on the gingiva. Now, this is the first biopsy that was taken. So you can see here is the epithelium, and that's the connective tissue. This is another sample, there's epithelium here, and that's the connective tissue. This one is a little bit thin. This one appears to be adequate, but there's not much pathology going on here because this tissue appears fairly normal. Now, this is the second biopsy taken. So you can see that's the epithelium here. You can see that the tissue here appears similar to what you've seen here. But then at this end, you can see there's something going on here. So you can see this is actually deeper away from the epithelium. All right. Okay, so if you were to take the biopsy only up to here, you will miss this lesion. All right, so this is the lesional tissue here, and this is after staining using antibodies, just to demonstrate that there is something else going on here. Now, this is the epithelium here, which did not pick up the staining. Sometimes we receive small and fragmented tissue. Now, this slide is just to show you one of them. Now, the clinical diagnosis of this sample was mucous extravasation cyst. So you can see the tissue here is fragmented. You see epithelium here. You don't really see much of connective tissue. You see a bit of epithelium here, and you see this thing fragmented in the middle. All right. So we really don't see that very nice mucin pool. So because of that, in order to demonstrate the presence of mucin, we actually have to do a special stain, and you can using Elsham blue, and it stains the mucin blue here. All right, so with small fragmented tissues like this, we may have to do extra tests in order to demonstrate what we think is the diagnosis. Once in a while, we will receive tissue which has been stored in the wrong solution, such as saline or saliva, or even in diluted or expired fixative solution. Now, this will cause tissue degeneration or lysis. So you must make sure that the solution that you use to store your specimen sample is the correct one. You have to use appropriate fixative solution of 10% neutral buffered formalin. Now, if you are taking fresh tissue for a direct immunofluorescence, you can transport them using Michel solution, or you can transport them in liquid nitrogen. But make sure don't use expired formalin because it can affect the tissue sample. All right. Inadequate volume of the fixative solution can also cause inadequate fixation. Now, this can also result in tissue degeneration, causing difficulty in the interpretation. To prevent this, the solution that you use to store must be 20 times more than the volume of the tissue sample. Avoid placing specimen on gauze, as the gauze itself can absorb the fixative solution, so it makes it difficult to separate the sample from the gauze later on. Now this is to show you fixative error. Now this sample has been stored in saline. So you can see how the staining is very pale and you can hardly see any cytological features here except these dots here and there. Alright. Now for tissue sample which has not been fixed properly, when we examine macroscopically, the tissue appears very soft and soggy. And macroscopically, you can see very pale staining with very poor cytological features. So it's very difficult for us to distinguish what the cells are. So to conclude, biopsy is important for diagnosis of a lesion. Now for cases of suspected malignancy or potentially malignant lesion, biopsy is the gold standard. A good biopsy with adequate tissue from a representative area will allow the pathologist to provide a more definitive diagnosis. However, errors can occur during tissue sampling and handling. So the clinician need to be aware of these errors and they need to understand these limitations and pitfalls in order to ensure that these errors are kept to the minimum. I hope this lecture has benefited everyone who's attending today and it can serve as a learning curve for you to improve on your biopsy technique and handling of these biopsy specimens. I would like to thank all the clinicians who have contributed to the case that I've used in this presentation today. So good luck and thank you for your attention.
Okay, thank you, Dr. No. Okay, all right. So again, if there's any question, you can type in the chat box. We will answer it later. So now I'm going to proceed with video 1, which is entitled Biopsy Technique. And this will be given by myself. I'm Dr. Liu from Omop Hospital Queen Elizabeth, Sabah. So in this video, I'm going to show you a few commonly practiced biopsy techniques that is usually seen in a clinic pergigian or in the specialty clinics. Okay, and because of technical issues, so I think I couldn't play the audio that I already saved, so I will just give you a live presentation. Okay, go on, share screen. Nampak tak? Okay, so you can see my screen, right? Okay, so okay, I'll be focusing on commonly practiced techniques such as smear or mucosal biopsy. I'd like to make sure if you can hear me. Okay, all right. So for smear, even though it's not really a biopsy, but it is commonly done in the clinic, especially in the oral medicine clinic, it's one of the exfoliative cytology, means we are examining the cells instead of the tissue. Okay, the main purpose is to rule out fungal infection. And as for mucosal biopsy, we have incisional biopsy and excisional biopsy. So the instruments that we normally use include scalpel, punch, as well as electrocautery or laser. Okay, so for a smear, what do we need to prepare is microscope slides. Okay, you may prepare 1 or 2 slides, disposable tongue depressor, as well as a container with alcohol solution. This is a fixative solution for the slide later. Okay, patient has given consent for this radiography. So in this patient, we are thinking that he's having burning mouth. So there might be possibility that he's having some form of candida infection. So the clinician has gently scraped his dorsum of tongue with tongue depressor. Then the exfoliated cells will be spread onto the slides gently. And then we use another piece of slide to spread it evenly. Okay, so now you have both slides with the cells. These slides will be put into the alcohol solution after it's dry, and then will be sent to the lab for staining. So under the microscope, if it is positive for Candida, this is what we will see. So we can see the purplish strands are actually Candida hyphae, and the epithelial cells at the back, as well as cellular debris in the background. Okay, now we come to mucosal biopsy. This is what you need to prepare for mucosal biopsy. Okay, I believe you have seen all these instruments during your OS posting or OM posting. Okay, now don't forget, the most important thing is a specimen container. You should have the patient's name, IC number, biopsy site, date and time taken, already filled up prior to specimen being placed into the container. And also not to forget your basic examination set, including probe, dental mirror, and tweezer, LA syringe, LA solution, and needle is either long or short, depends on the location of biopsy. Scalpel with blade. Usually we use blade 15. However, in certain cases, for example, in perio, for perio clinicians or specimen on the gingiva, you can choose to use blade number 12. Okay, and tissue forceps, you can use either non-tooth forceps and tooth forceps, but be careful when you grasp the specimen using the forceps. A tooth forceps will, it's not only tooth forceps, but both forceps, when you put it extra pressure, there will be crush artifact on the specimen. So be careful when you're using the tissue forceps. And also the retractor, butt cheek retractor, and also tongue depressor when necessary. And not to forget your suture material, Vicryl 3.0 or 4.0. You can use a silk material if you plan to retract the tongue. For example, the lesion is very deep at the posterior tongue. Okay. And artery forceps and needle holder. I believe you have seen all these instruments, but then you need to know the difference between artery forceps and needle holder. And your scissor for tissue and for suture. And also gauze and Surgicel. Okay, here's the guidelines for appropriate biopsy by Oliver et al. In 2004. Okay, so in this table, the author has summarized the common oral lesions and also type of biopsy that is desired. Okay, for example, if there's a chronic ulcer, non-healing ulcer, and you want to rule out if there's SCC. So usually what we do is incisional biopsy at the margin of the ulcer. Okay, we don't really take the central necrosis part or central inflamed part, because what you'll be getting in the end is only non-specific ulcer or probably chronic inflammation. Okay, and for example, mucosal lichen planus, incisional biopsy of representative area can be done. For example, at the area that you see white striation or area that you see erythema. Okay, so and also for bullous lesion like pemphigus, pemphigoid, incisional biopsy can be done, but it's not at the distal site, but it's at the perilesional area on the mucosa close to the blister. Okay. Here's a few pictures from Avon and Clip in 2012. The author shows the biopsy site of a homogeneous leukoplakia. So there is whitish lesion over the right lateral border of tongue. LA was given. And also here's the incision site. Okay, so you can see it's an elliptical incision with ratio of length to width of 3:1. Okay, it's an ideal incision. Okay. And before the incision starts, you need to give LA. So here's another technique we call it 4-point technique, where you give 4 points of LA infiltration surrounding the lesion, not too close. If not, you will cause cellular edema. Okay, so of course, if you might need to give additional infiltration if patients still complain of discomfort or pain. Okay, here's a video. I'm going to show you an incisional biopsy. It's an ulcerated mass on the oromucosa, for example, on oromucosa. Okay, I'm using a non-tool tissue faucet. I've selected an area, so LA was given. And of course, this is just for demonstration. And of course, in the oral cavity, it will be more difficult than doing it on the table. So now I've included part of the tumorous area, the reddish area, as well as a little bit of surrounding normal mucosa. I try to make it an elliptical incision. Okay, so when the biopsy is done, the specimen should be placed immediately into the formalin. Okay, if you are not able to do it, please at least put it on the dampened gauze, but it's just for a short while, you cannot place it for too long. Okay, so for small specimen like this, you can put it on a rigid piece of paper or cardboard. The best example is a suture packing material. Okay, just cut it a bit and then you place a tissue on it before you place it into the formalin solution. This will prevent the shrinking, not shrinking, this will prevent the curling of the specimen later. Okay, here's another video showing another technique of doing biopsy. I place a suture across the biopsy site. So this is, just imagine this is an ulcer. Okay, so I plan to take this area, include part of the ulcer and also part of the normal mucosa. Okay, gently pull it. You can either tangle the suture around the artery. Okay, now I'll continue with the incision. Okay, now it's done. So this is another method of using the suture to hold the specimen. Okay, here's another example. Patient has given consent for this video. There's a non-healing ulcer on the left dorsum of tongue. So similarly, the surgeon used the suture to hold the specimen, but be careful when you're doing this, especially when patient is having limited mouth opening. So you may use a mouth prop if necessary. Here's the surgeon made the knot. Okay, so this is another method instead of tangle the suture around the artery. Okay, hold it and then before you cut the suture. Okay, now when it's stable, you can start the incision. Okay. Sometimes patient tends to move her tongue, so with this method, it is easier for the surgeon to control the tongue, as well as for retraction. In this case, we want to rule out if this is SCC. So instead of the central ulcerated part, the surrounding normal mucosa is also included. Tak gerak ke? Okay, now you can see there is some bleeding over the incision site. The DSA should, apart from try to retract the oral tissue, suction can be done or use a gauze to stop the bleeding and to clear the view for the surgeon. But remember, do not place the suction tip directly to the base of the incision, but instead you can just put it at the peripheral area and then gently swipe around the incision site. Okay, so now it's done. The specimen is placed immediately into the formalin. But be careful, if your instrument has contact the formalin, and please do not reuse it, change it to a new one. Okay, so these are a few pictures showing how you should place your suction tip. The first picture is not so correct, so you just place it at the periphery. Alternatively, you can use a gauze. Okay, now we come to punch biopsy. Okay, punch biopsy might not be so familiar to all of you, but sometimes it is used in oral surgery clinic, but mostly it is used by the skin specialist for skin biopsy. So a punch actually consists of plastic holder as well as circular blade at the end, which is attached to the plastic holder. There's a circular blade. Okay, there's various of size, range from 15 mm, 1.5 mm to 10 mm in size. Okay, so the blade is actually sharp and is cutting. Okay, the good is this is quite user friendly, and then the procedure of taking a tissue specimen is quick. However, there is a certain area that only allows punch biopsy. It's not suitable for all the biopsy sites, and also you should have sufficient thickness of tissue before you want to when you want to do punch biopsy. Okay, now I'm going to show you how a punch biopsy is done. Now there is an ulcerated lesion on the right hand side. So the cutting part is actually the circular area. Okay, before this you give LA. And then this punch should be placed perpendicularly to the area that you want to do biopsy. Okay. Then when you want to cut, slowly, gently push the punch inwards and then rotate clockwise. So you push and rotate, okay? Okay, you should not put it to full thickness because the entire, it depends on how much you want to take. The entire thickness of the blade is about 7 mm. Okay, in this case, I'll take only for 5 mm. Okay, so when I want to remove, I rotate the blade anti-clockwise, and now you can see there's a circular cutting mark. Okay, now get the tissue forceps, hold the specimen. Then you can use a scalpel blade to remove the tissue from the base. Alternatively, you can use a tissue scissor. So now you get a specimen. However, the incision itself is a circular or a circular one, so it's not elliptical one. So some authors say this could be slightly difficult to approximate the wound. Okay, so for vesicular-bullous lesion, for example, pemphigus vulgaris or mucous membrane pemphigoid, sometimes we do DIF, which is direct immunofluorescence. This is another technique apart from normal routine H&E staining to determine the deposition of antibody if the disease is present. Okay, so for DIF, we take from perilesional skin, which is this area. Usually we cut and then we separate the lesion into the specimen into two. So one will be fixed with formalin. Another one, you don't fix it with formalin, but we put it in another solution, which I will explain later. Okay, so DIF is actually, we'll see it under the fluorescence microscope. It's actually antibody react to the antigen in the tissue. And then this is what we will see. In this case, this is a pemphigus, so we can see like the position of the antibody within the epidermis. Okay, so this is not really a definite diagnostic technique. However, it will help in our diagnosis of this case. Okay, this is Michelle solution. We use it to fix the fresh tissue that we get from the specimen just now. Okay, you can either put the specimen directly into the solution, or you can place it on the gauze, which has already soaked with this solution, and put it in the formalin in the specimen container. Alternatively, if you don't have Michelle, you can use phosphate buffer solution as well. Okay, similar technique. Put it on the dampened gauze, which is already soaked in PBS, and in the formalin in the specimen container. And then don't forget, you need to place it in a cool environment. So get ready a polystyrene box like this, and then put in an ice bag, and then you put in the specimen container, and then you close the box and send to the lab immediately. Okay, now we come to excisional biopsy. So the same ulcerated mass again. So fast forward this. Just imagine the excision of the lesion has been done. Okay, now for excisional biopsy, what we sometimes concern is the orientation of tissue. So this is how I'm going to place the orientation suture. Okay, the suture will be, you take a deep bite for the suture, and then you can do a simple ruptured one or a loop. And then sometimes you can put it like one long suture or one long, one short suture, indicate different margins. This should be done on the specimen when it is totally removed from the oral cavity or from the patient. Okay. This will help the pathologists to determine the orientation of the specimen whenever they want to do reporting. Okay, so similarly, excisional biopsy is not like the big specimen like SCC that surgeon do in OT. In clinic pergigian, sometimes I believe you do excisional biopsy as well. For example, mucocele or fibroepithelial polyp. If you think the lesion is not too big and then it's excisable, and then actually you can just proceed with excision. Okay, as long as you're able to control bleeding and approximate the wound. Okay, so these are the reference for my presentation. With that, I thank you. Okay, so I think this is the last presentation for today. Now we have our Q&A session. So we will show the questions by participant just now, and each question will be answered. Dr. Zari, you will show share the question to all of you. You might raise hand and request to speak if you like. Okay.
Okay, hold on, Doctor. We only received 2 questions from the chat box daripada awal tadi. So the first question is from Dr. Gabriel Chai. For Dr. Savan punya lecture, the second lecture, she says, hi doctor, can discuss a little bit on how medications and blood treatment plays a role in reaching a diagnosis for oral lesions. So for medications, I can only think of drug-induced gingival hyperplasia and maybe candidiasis. So can we discuss about this, Dr. Savan?
Thank you, Zarif. Thank you, Dr. Gabriel. I looked at your question. I assume that you are asking in the from the aspect of histological diagnosis, yeah? Okay, so your question got 2 parts. One is how drugs will give some clues, and the other one is the blood investigation. I think in terms of drug, at the moment I don't have much to say. Probably like in OLP, OLR, there will be a history of drug intake. If you look at the patient's drug list, there will be quite a number of significant drugs. They will be taking certain drugs which can induce these lesions inside the mouth. So that will like some sort of supporting our diagnosis. Okay, the other one is now we go to the blood investigation. So you're asking about how this investigation results when you convey to us the result. It will help us in reaching the diagnosis, right? Okay, I just go through by giving a few examples. Okay, especially for us, like drugs that I can think of when we are dealing with hematological malignancies. For example, if you think patient is suffering from leukemia or some kind of lymphoma. So in hematological malignancies, we need to have certain evidence showing that this patient is having disturbances. For example, FBC, you can see the results, the WBC, the count will be altered. Not only WBC, the differential count, you can see it will be altered. The peripheral blood film, for example, this one, whatever the finding on peripheral blood film, that can also give some clue towards the hematological malignancy. So if we have these clues, this information, and when we combine with the tissue, the histological part, when we see under the microscope, we will be quite sure and we can explain why these changes are being seen. And also, when you tell us that this patient is having such a thing altered, we can think of how to plan for our staining and other things for the patient. Where is it leading towards? Especially for a difficult case where it needs multiple stains. So we will be able to plan where and which path we should take. Okay, another example for blood investigation. In immunocompromised patients, if the blood says results or serology results says that patient is HIV. Now this, if you are aware, plasmablastic lymphoma, we have an entity called plasmablastic lymphoma. This is mostly seen among HIV patients. So if there is a history of HIV, you tell us that yes, patient is a HIV patient.
we will be quite sure with our diagnosis. So if let's say patient doesn't have HIV, then we will be saying that might be consistent, or the features that we are seeing is towards, our staining is towards plasmablastic lymphoma. Please do further investigation to rule out or to confirm whether patient is immunocompromised HIV, for example. Kaposi sarcoma, this is common among HIV patient as well. So if you don't get to see, mostly you don't get to see in a young healthy patient. So how do we know that we are in the right path? So we need this kind of information to further proceed with our staining. Okay, so let me give you another example. Multiple myeloma. Multiple myeloma is related to plasma cell pathology of plasma cell. And this one we can't diagnose just by looking at the histology. No, if let's say you don't tell us that patient has got other features like Benz-Jones protein, presence of Benz-Jones protein in the urine, and other features, we will only sign it out as plasma cell neoplasm, because we need other information to tell that yes, this is multiple myeloma. So that's why we request for blood investigation, and if you have these results with you. Other thing, which I think maybe I can give another example, like OLP and lupus erythematosus, that we have discoid lupus erythematosus in the mouth, on the oral mucosa. OLP and lupus, they look similar. So what will be differentiating that for us to tell that this is going towards lupus is that we need the serological findings, the antibodies through the lab result. So if we have this supporting information, we can tell that we can let you know, or we in the report we will be signing it out and telling you that yes, it supports with this, all these results, this evidence, our histology is looking towards this lupus. Okay, so another one is the Sjogren syndrome. If you look at for Sjogren syndrome, you take a biopsy of the salivary gland, it just shows atrophy, like what I showed in the lecture just now. You see a lot of atrophy, destruction of the salivary gland, and all this infiltration of chronic inflammatory cells. But with just that feature, we can't tell it as a Sjogren syndrome. But if you include in your report that there is some antibody, some serological tests, positive serological tests for Sjogren, certain things you mentioned, the appropriate one, and then we see under the microscope that these glands are having changes like what I mentioned. So we can correlate these two are going towards a Sjogren syndrome. So we can tell you in the report that this is towards Sjogren syndrome. So I hope I have answered your question. There are a lot more to discuss, but I don't think I'll be able to mention everything. But I just picked a few that is common and a few examples to show and share so that you get a clearer picture why we always go after the officer asking for extra information when we are issuing out the report. So yeah, I can see in the chat box that Dr. Gabriel has responded saying that he understood. So if you are clear and you can accept my explanation, I'm happy. Thank you very much.
Okay, thank you, Dr. Savam. Okay, the next question from Dr. JC Wong regarding Dr. Nur Shalin's third presentation. She asked, in your opinion, what is the appropriate tissue size we should take to prevent inadequate sampling? Dr. Nur, boleh share?
Right. Hi. Okay, answer to Dr. JC Wong. Although Dr. JC Wong, I assume she would already know the answer, but all right, I will answer her question. Now, we must think when we take a biopsy, now the tissue has 3 dimensions, yeah? One is the diameter across, all right, anterior to posterior. The other diameter is from sideways, so medial lateral, and the other diameter is the depth. All right, so there are 3 diameters to a tissue. Now, this is the measurement that we make when we actually gross the specimen. You can actually see this in our report. All right. Now, for a minimum size, now a lot of you have adequate. Most of you will have taken adequate length. That is the diameter, and also the width itself. But usually, there are some specimens that are inadequate depth. So it's too thin, all right? So it's the top to bottom depth. Now, if you read, the minimum depth should be more than 5 mm. Okay. Now the diameter should be more than 6 mm, and the across medial lateral, the width should be more than 2 mm. Now this is after shrinkage is over. This is what we would like when we gross the specimen. Sorry, can have a. All right. So this is when we gross the specimen. This would be the measurements that we get. So, but your specimens that you take should be larger than this because it will shrink. The formalin itself will shrink your tissue to a smaller size. So, in my opinion, the best is if you can take something that is about 1 cm to 1 cm across, 0.5 cm that way, 1 cm length, 0.5 cm across, and 0.5 cm deep. That will give you a little bit more room to play around with. But of course, it depends on what tissue you're taking. For example, if you're taking from the tongue, then that's all right, you have adequate. If you're taking from buccal mucosa, you have adequate. But if you're taking a cyst, for example, like a dentigerous cyst, you're taking an incisional biopsy or an OKC, then it's not possible for you to achieve this dimension, all right? So the dimension is just a guide, all right? Okay, so I hope that answers Dr. Jessie Wong's question. Now, there's another question, yes, Ari?
Yes, sir.
The second question.
The third question is from Dr. Wong Wailin. He asked, can we use suture to hold the mucocele instead of tissue forceps during the biopsy? I think this one is for Dr. Liu punya presentation, the 4th presentation.
All right.
Okay, hi. Yeah, betul.
Yeah. Go ahead, Liu. Sorry. I'm answering on your behalf.
Okay. Okay. For this case, I've seen there's suture across the mucocele. However, it should be at the from the deeper instead of you rupture the mucocele punya sac tu kan. So you go from bawah tu, and then because you need to also excise the accessory gland, right? So yeah, you can use, but then be careful. Ada mau tambah ke?
I'm muted. All right. Now, I think for mucocele, now if you put suture, you got to be very careful because you must understand what a mucocele is. A mucocele is actually a cyst. So if you put a suture right through the cyst, then you will rupture the cyst. And so the tissue will tear off. Yeah, right, Liu? So if you want to put a suture, you have to go deeper than the cyst itself. Because once you rupture the cyst, we will not be able to view the mucin. And I think in my lecture earlier on, there's one tissue that shows fragmented tissue. So we can only see very little mucin. And so we have to do extra staining to actually demonstrate this mucin. So extra staining means extra time. So it means your report will come up later. All right. So if you want to put a suture, it's for mucocele, but it has to go deeper than the cyst itself.
Yes.
So you have to imagine how deep your cyst is. You have to go deeper than that, not to go right through the cyst because it causes rupture and you get a fragmented tissue. All right. I hope that answers your question. There's another question, Sari?
Yes. Okay. The next question is from Dr. Irisha. Hello doctor. For situations where patient lives far away from hospital, if we are from a rural area and we don't have proper fixation solution for the biopsy, is there any alternative that we can use? Or would it be better not to do the biopsy at all and just refer for biopsy? Thank you.
Liu, you want to
Yes,
answer
doctor.
or should I answer? Should I answer? Do you want to answer?
Oh, I just give a bit of opinion on this because, all right, if you're from rural area but you don't have a proper fixative, because the formalin is the standard fixative solution for biopsy, so actually there is no other alternative that you can use. Yeah, maybe you should just refer the patient straight away to the hospital for like proper management lah. Yeah, doctor, what do you think, doctor?
Yeah, I agree with you. If you Google, you probably find some alternative to it, but as you said, that formalin is the standard for fixation of tissue biopsies. Now, our staining technique, which is using chemothoxylin and eosin, is actually based on tissue fixed in formalin. So if the tissue is fixed in other alternative media, then the staining might not be similar, and that may also affect the interpretation of the slide later on. So because we are used to seeing H&E staining for formalin fixed tissue. Now, I'm not sure whether that will affect, because if later on we need to run further stains, for example, immunohistochemistries, this is using antibodies and a different type of staining technique. It might not work if you use an alternative fixative solution, because most of this IHC, they work on formalin fixed tissue, all right? So that may create problem later on. So if you are unable to get any formalin, then I suggest you send it to the nearest OMFS clinic for management. Or if there is another clinic nearby that has formalin and the officer is capable of doing the biopsies, then that would be another alternative. All right? Okay? All right. I see there are more questions. And you want to add further, Liu?
Not really, doctor. Your explanation is very good enough.
All right. I think the next 3 questions are for you.
Yes. So the next 3 question is again from Dr. Gabriel Chai. So hello doctor, regarding the topic of biopsy. So the first question is there a reason we can't suction the deeper part of the incision? So should I read out all ke atau you answer one by one dulu doctor?
I try to answer one by one lah.
Okay, so the first question is that one lah.
Yeah. Okay. The reason you cannot suck at the deeper part, or you're not advised to suck at the deeper part of the incision, is that sometimes when the incision is not done or almost done, and you place a suction tip over there, you might accidentally suck the specimen away. Right? If the incision or the specimen is very small, so there is a risk of the DSA suck the specimen away. And for me, because the suction is for you to clear the blood, all right, it's not to like induce more bleeding from the deeper part of the incision. Yeah, that's my opinion. Dr. Noor, you want to add anything?
Yeah, be careful with using suction, because especially if you're taking very tiny tissues or fragmented tissues, because if you use your suction too aggressively, you will end up sucking the tissue instead. So
Yes.
the tissue will become distorted. So be careful with that. So you should actually suck around that area to actually allow the person who is doing it a better view. All right, to remove whatever fluids around, so that they have a better view, so that they'll be able to carry out the biopsy. So, but so I think so you got to be very careful with suction. Okay.
Yeah, I think that answers the question, I think. Yeah. So I saw second question.
Yes, second question.
Solution ES
sorry,
alternative to formalin.
Teruskan
Okay.
doctor.
Yeah, okay, all right. because I can see it from the chat box, right? Okay, so or they are just transport medium, which one requires storage in cold condition? Actually, phosphate or buffer solution is like formalin, but then this is for different purpose. Okay, so you place a specimen inside the solution, and then for whenever you want to do DIF, or like you want to plan for frozen specimen, for frozen section, then this specimen should be stored in cold condition. But if formalin, you don't have to store it in cold condition. Okay, betul kan Dr. Noh?
Yeah, I think this was in my lecture earlier on. Michelle's solution is a different type of solution. It's actually not for all oral biopsies. Michelle's solution is when you want to transport the tissue and request for direct immunofluorescence. Now, this is a test that we will require if you're thinking of vesiculobullous lesion, all right? But formalin is the fixative solution that you use for all other tissues that you want the routine H&E slides, all right? So Michelle's solution is an alternative to transporting fresh frozen specimen for direct immunofluorescence. So you don't need a cold condition for transportation for formalin fixed specimens. Okay, I hope that answers Gabriel's question.
Okay.
All right, there's another question.
Yes. For exfoliative cytology, how do we store the slides that have been spread with the sample so it can be transported to OMOP via flight? Usually we don't really send the slides to other places, because here we have our own lab, so we directly send the slides to the lab. So actually, I mean, if you don't have a nearby lab, it's not advisable to do this procedure. Yeah, Doctor, what do you think, Dr. Noor?
Yeah, for exfoliative cytology, which is smear, there are two types of smear, dry smear or wet smear. Now, dry smear is you transport it after your smear is dry, okay?
Yes.
But that one you need a lab that is nearby so that you can transport it immediately, all right? If not, the whole tissue will spoil later on. So, but for a wet smear, you can actually transport it a little bit later. Now, for wet smear, when it's wet, you have to kind of fix it, all right? Now, but this fixation is slightly different from your formalin. It uses alcohol, but a certain concentration of alcohol.
Yes.
We tried this before when I was working in University of Malaya, where we tried different techniques of fixing for wet smear, for exfoliative cytology, for FNA. We've even tried using hairspray, because hairspray is some form of alcohol. So to fix it, you kind of spray onto it. So it when it's wet, you spray immediately, so it gets fixed immediately. So it means that the slide can be transported and be processed later on for staining. Okay, but I assume this is from Dr. Graybill, isn't it? Yeah.
Yeah.
So Dr. Gabriel is working in me, and currently there is a pathologist, and she actually reads cytological smear. So you can actually send it straight to the pathologist there. But they do not offer histopathology service in Miri. They do offer cytopathology services. All right, so this is different. Cytopathology is different from histopathology. Okay. The preparation of the slides are slightly different. They don't undergo the same process that the tissue, your tissue specimen undergoes. So it's a little bit different. All right. I hope that answers Gabriel's question. Any other questions, Abby?
Yes, ada lagi satu question, Doktor, from Dr. JC Wong. For erosive candidiasis, will you recommend smear biopsy or incisional biopsy?
JC Wong. I thought JC Wong not allowed to ask questions. All right. Now, okay. I think for Candida, you want a quick answer? Of course, smear. Okay, rather than an incisional, because incisional will take a long time. All right. Now, but but I think candidiasis is more of a clinical diagnosis. The smear can help to confirm your clinical suspicion. However, if you are saying that the candida is part and parcel of another white lesion that you suspect to be a leukoplakia, then it's best that you treat the candida first with antifungal, because presence of candida within that tissue will affect your epithelial dysplasia, because the presence of candida can cause cytological atypia very similar to dysplasia, and so it will affect the degree of dysplasia that's reported. But if you have given antifungal prior to your biopsy, it will remove the fungal infection. Then we can get a better picture of what's the degree of dysplasia that's present within that lesion. Okay. I hope that answers Jessie Wong, but Jessie Wong will ask me later again in the chat if she doesn't understand. Anyway, there's another question that
Just
was
satu lagi daripada Dr. Jackson. Sorry, missed out this question just now. Morning, doctor. May I know there is a time frame for a freshly cut specimen to reach the lab, as this is especially difficult for clinic in the rural area to have to deliver it in a short amount of time lah.
Liu? Boleh jawab, Liu?
Dr. Liu unmute.
Yes, saya sudah unmute.
Okay.
Okay, for this question, there is not really a time frame. Tapi once you cut the specimen, you just put it into the formalin, and then there's a minimum fixation hours, like 4 to 6 hours, depends on the size of the specimen. And then if you want you don't have to really worry about the delivery, as long as it's not too long, like 1 month, 2 months. But then as soon as you immerse in formalin and then send it to the lab, and then we'll do. Did I answer your question especially clearly? I don't. You can just try to post. I understand that because in some rural area it takes sometimes a few days to reach the lab. Tapi we usually receive the specimen like 1 week, like a few days or 1 week after the biopsy. So do not worry. You just send as soon as possible. Dr. No mau tambah.
I think he's asking for freshly cut specimen as well, but I don't know whether he meant freshly cut is in for fresh tissue, because fresh tissue it has to arrive soon.
Immediately.
Within because if you're thinking of but then you must understand fresh tissue, what are you requesting for? Because if it's fresh tissue, then you're thinking of vesiculobullous lesion, then we're thinking of fresh tissue.
Liquid nitrogen.
The liquid nitrogen, fresh tissue for margins, but that would be done within the hospital itself and not in the primary care setting. So for primary care setting, I think there's very little need for you to take and send fresh tissue. Most of it will be formalin fixed tissue.
Yes.
All right. So I hope that answers your question, Jackson. Jackson or Jackson? Sorry. I'm not making fun of it.
And can I add, like, if you plan to do for example, you want to rule out that if there's a, let's say, pemphigus vulgaris, please communicate with the oropathologist nearby, and then so we can advise you what to do, how to do it, and then make sure you have you can send the specimen immediately. Like if it's very far away, then usually you cannot do also, but you can always call to consult lah. That's all.
Here I see Jackson says for formalin fixed tissue. I guess we cannot prolonged formalin fixation also affects the tissue, but this will be it doesn't reach us until over a month or 2 months, then there is problems in the tissue later on. Okay, now just to share you, there was another question someone asked at the side. All right, is the use of instrumentation that can cause thermal artifacts such as electrocautery, laser, and also diatomy. Now, if you have taken adequate margin, if it's like, for example, the malignant lesions, and you have taken an adequate margin, then thermal effect will not be a factor because it might, you probably, if the margin is clear, then that should not be an issue. But if your margin is closed, then thermal artifact can make it difficult to interpret the presence of dysphasia or tumor at the margin. All right. Now, one way to reduce this thermal effect when you're using this electrocautery or diatomy is to use the cutting mode only when you cut, rather than use cutting and coagulation mode at the same time. Now, cut it first, you use coagulation mode to buzz the area around it to reduce the bleeding. So this is one way to reduce, to minimize the, what do you call it? The thermal artifact. But if the lesion is like a benign lesion and margin is not an issue, then having that thermal artifact does not really affect much in interpretation of the margin. All right. Or if you have taken really big margins for malignant lesions, your margin is adequate, then interpretation of these margins where there is thermal artifact should not be an issue. Okay. I hope that answers your questions. All right. So no further questions?
From the chat box, tak ada question lagi lah, Doktor.
Sabam, you want to say some last words for today? Or you want to say any housekeeping rules?
Yes.
I'll give it to you. Okay. So I hope to see you guys tomorrow, and I hope you have enjoyed our session today and you've learned something today. All right. I will hand over to Dr. Sabam. She will give you some housekeeping rules. Okay. So we'll don't forget to fill in your attendance. It's in the chat box, and all right, because we need that in order for us to give you a cert later on. Okay. All right. Thank you. See you tomorrow.
Thank you, Dr. Sabam.
Okay, I just want to remind about the housekeeping rules, like what Dr. No mentioned just now. Please fill in your attendance form. We will only provide certificates, e-cert, for those who have attended the course and have showed the evidence of attendance. That is by filling up the attendance form. Okay, I see someone is asking there, where is it asking for the attendance form? I have shared earlier. I'll share again in the chat box. It is in the chat box. The link is there. And tomorrow we will be providing another attendance form and also the feedback form. Okay, the other thing that I would like to remind is that tomorrow we hope all of you can be here on time. And we will not accept any entry after 9 a.m. because those who log in during a lecture, it is very, very distracting for us. So I hope everyone can be here on time, the latest by 9 a.m. And I think that's all from me. Dr. Liu, you have anything to say?
Okay, thank you, Dr. Sabam. So, so again, just want to emphasize, please be here on time tomorrow morning. Yeah, and then if you have any further questions that you tak sempat want to ask, you may send an email to Opom Sarawak or Opom Sabah. We'll be more than happy to answer your questions. And then, okay, so for now, I think we have completed all the planned activities for today. And if there is no other question, we'll call it a day. And we shall meet again tomorrow morning. Please enroll yourself on time using the same link as provided. And we look forward to see you tomorrow. Yeah. So thank you.